Good morning, good afternoon, good evening, good night, depending on where everybody is around the world. Thank you for everybody that has joined us for today's webinar hosted by the CLL Advocates Network. For those who aren't familiar with CLL Advocates Network, the CLL Advocates Network is a network of organizations around the globe who have come together to help build capacity to aid support in different countries of CLL patients and their families. Today's webinar is looking to explore latest treatment technologies and treatments and care and management of patients in the relapsed, refractory and setting where people have failed a prior treatment. After introductions, my friend and colleague Brian, Dr. Brian Koffman, will give you an explanation of this setting. Hi, Tal.
Oh, hi, Nick. Sorry, I lost the link somewhere. And
That's okay. We've just started the webinar and I'm just about to go through introductions. So that's a really timely start by yourself. So if I introduce myself, my name's Nick York. I am a CLL patient. I think I was diagnosed some 13 years ago. I had a period of about 7 or 8 years on watch and wait, which at the time I wasn't sure about, but I really did enjoy. And then I had my first treatment with FCR some 5 years ago, and I managed to get a couple of years remission stroke treatment gap before I started my second therapy. I'm also the chair of the CLL Advocates Network, and I'd like to hand over now, if I can, to my friend and colleague, Dr. Brian Koffman, to introduce himself.
Good morning, good afternoon, good evening, good night. I'm in sunny California here, so it's morning here, but not too early. I'm Dr. Brian Koffman. I'm a retired family doctor, and like Nick, I'm a CLL patient myself. I was diagnosed in 2005, and I was telling my story online through a blog, and that later morphed into, with my wife, co-founding the nonprofit CLL Society, where I serve as the chief medical officer and the executive vice president, and it's founded on the 4 pillars of advocacy, support, research, and education. I also am privileged to serve with Nick on the steering committee of CLLAN.
Thank you very much, Brian. It's a pleasure to have you with us. And Lilia, would you mind introducing yourself next?
Yes, well, hello, everybody. I'm speaking from chilly England. My name's Lilia Dewley. I was diagnosed with CLN in 2009. I had maybe 10 months on watch and wait and had FCR in 2010. I had about 4 years after that, was relapsing in 2016, and in 2017, I went into the Clarity trial. So I had ibrutinib and venetoclax, and I'm an associate trustee with CLL Support, which is a support charity for people with CLL in the UK. And I also work with Talha and some of his colleagues on, I'm a patient representative for the FLAIR trial and the STATIC trial in the UK.
Thank you, Lilia. It's a privilege to have you with us today. It's nice to be indoors, and I've got my heating on at the moment. It's turning chilly in our neck of the woods, as you say. Tal, thanks so much for really taking the time to prepare your presentation and join the discussion today. Please do introduce yourself.
yeah, thanks a lot. Thanks, Nick, Brian, Lilia. It's an absolute pleasure to be here. I'm Talha Munir, one of the hematology consultants. I work in Leeds, UK, and I'm just now taking over a lot of CLL work from my mentor, really, Pete Hillman. So essentially doing quite a lot of clinical trial work in UK, and privileged to be here to kind of discuss all the issues that I'm pretty sure we'll have a very healthy discussion later on.
Thanks so much, Tal. Before we sort of wade into the session, there were a couple of things I just wanted to note again, just for housekeeping purposes. Again, I'll reiterate that please use the chat if you've got any questions that come up during Tal's talk. We'll look to address these during the discussion that follows. We have a bit of time. We won't stay on too long if discussion dries up, but I don't expect that to. So thanks very much for that. And just to reiterate as well, to get everybody an idea on the call, that I think we've got quite a mixed audience. We've got an audience of advocates, representatives of charities in different countries that support patients and their families with CLL. Some may be CLL patients themselves and have a good knowledge of CLL. Some may not. Some may have CLL in their support remit, but don't know a great amount about how CLL patients in the second line and beyond are treated. So this will be very informative. Also, the American Society of Haematology Conference is about to start. So again, I must offer my thanks again to Brian and to Tal, who are both traveling to New Orleans for this important conference where the latest developments in CLL are announced. So this is an opportunity for some foundation learning for advocates that for the second year only have been allowed to join the ASH conference in the capacity as advocates. And so this will also serve as some foundation learning. There are other stakeholders who are also advocates for CLL patients and family, and different stakeholders who will also gain the benefit of some depth of knowledge. But most importantly of all, this webinar has been open to patients. So the information will be very useful for patients who are also considering second treatments or are looking at how treatment is, how CLL is treated, you know, in the second line and beyond. So I just wanted to bring that up together. I also wanted to point out that there will be quite a lot of technical slides during this session, and Tal will do a terrific job of talking his way through them slowly. But just in case you struggle and you find some of these hard to understand, this session is being recorded and you will receive the video within 24 hours of this session with the feedback form and request, so that you can actually revisit these at your own leisure and then, you know, absorb the information at your own pace. And I'm going to ask you a little question, if I can tell, before I give you the kickoff signal. Obviously, this session we're discussing CLL in the relapsed refractory setting and those that failed a prior treatment. Would you mind, in the most basic of terminology and language, explaining relapsed refractory and this whole group? Just because I think that's an important thing, bearing in mind as well that English isn't everybody's first language.
Yeah, thanks, Nick. So I think the question really is about relapsed refractory definition. And if you look at the definition of relapsed refractory CLL, it can mean different things to different people, but in simple, plain words, when we are saying relapsed refractory CLL is somebody who's had any treatment for CLL in the past, whether a person has had one line of therapy, which means could be very gentle treatment in the form of a tablet called chlorambucil, and then some patients have had very strong treatment, like combination of fludarabine, cyclophosphamide, and rituximab. And if we are in this era of targeted drugs, some patients would have had targeted drugs like ibrutinib or acalabrutinib. So if you relapse after you received that treatment, then we will call that as relapsed refractory CLL. And then the clinicians will use the words, whether there is first line of treatment or second line of treatment, third line of treatment. There is slight difference between relapsed and refractory CLL. Refractory CLL means that if you had that treatment and you did not respond to therapy at all, or your relapse was very quick in the first 6 months after you finished therapy, then that is classed as refractory CLL. But in simple, plain words, if I have to describe that, is anybody who had CLL treatment for the first time and now they need another line of therapy, that is relapsed refractory CLL.
And Nick, I'm going to jump in with a second question for Tal here, just along that lines, because another reason people switch drugs is not that the drug isn't working, but they can't tolerate it. They're intolerant. Can you explain the difference of that and maybe touch on that definition and how that plays into, because that's becoming an increasingly important issue as a patient. Yeah.
Yeah, that's a very good point, Brian. And tolerance is one of the major issues with any continuous therapy, and we are going to talk a bit about it. And when somebody is becoming intolerant to a drug like a Bruton tyrosine kinase inhibitor like ibrutinib, then it very much is dependent on why that patient is stopping. If somebody is intolerant to that treatment, then they can switch over to another therapy and may still have the benefit of that molecule. So that's really not a relapse disease. It's primarily intolerance to that treatment, and that is different to the relapsed refractory CLL that we're talking about. I think it becomes a bit convoluted because some people who get ibrutinib in the first year and they stop it, then the relapse is very quickly on these targeted drugs. Whereas if you had ibrutinib for 6 years or so, and then you stop, then you might not relapse very, very quickly. So they go hand in hand, but definitely intolerance is becoming a big group, and there's quite a number of, quite a bit of data now accumulating that intolerant patients, we still have options for those patients. If you're intolerant to one drug, and you can use another class of another drug in the same class if needed.
Thank you, Tal. That was very comprehensive. I don't know in your talk if you're going to reflect on intolerance at different points, but that was really helpful separation and distinction. Please now do proceed with, if you're happy to share your slides, and we're looking forward to your great talk.
Now it's about technology now, Nick. I'll try to find the slides.
If you're not happy sharing your slides, one of the team can do for you. The green button at the bottom would allow you to then source your slide and then share it and put it on screen. But if not, Nicole, who's on the team, has your slides and can share them for you if you just ask them, to click through as you require. Excellent. That's on slideshow.
Oh, brilliant. Thank you very much. So Nick has asked me to give a talk on the treatment in relapsed refractory CLL and what therapeutic approaches are there. So I think whenever I talk about CLL, it's very important that we talk about the aim of treatment in CLL. Previously, one of the major aims of treatment of CLL was to control the symptoms, to improve the quality of life. And by that, I mean that if we give therapy, whether we can improve the patient's quality of life. And hand in hand, it was related to whether we can control the disease better. And now we are coming to an era where we are thinking about whether we control the disease, improve the quality, improve the symptoms, but then we give patients treatment-free intervals as well. And ultimately, we want to prolong the survival and also move towards the cure of CLL. And that is influenced by a lot of things. And these are some of the factors that we consider, what is possible to give to a patient. So a very young patient might be able to tolerate chemoimmunotherapy in the form of a treatment called FCR. But a lot of patients, where our average CLL patient sometimes is at age of 71, we have to consider what are the comorbidities and what treatment would be the best choice. But now that kind of is devolving a little bit, because we are able to use the targeted drugs in majority of the patients. And then patient choice is very important for us, because Some patients would like to have just simple tablets to take at home, whereas some of the other treatments, like treatments that we give in the hospital, they are a bit more intrusive. And I think we will most probably talk about COVID as well, and that will have an impact on the choice as well. And in relapsed refractory CLL, it also depends on which treatment has been used in the past. Has the biology of the disease changed? And very important is that in the area where we are living, what therapy is available. And then we have to strategize based on that. What are the future options in that respect? I think that is an important thing, that we need to set the treatment goals early on. They can be challenging, but it's a discussion between the patient and the clinician to choose the treatment goal. And I'll just give you an example that you may want to have very good response and very deep remission. So you might want to have the intensity of the treatment in the first year of therapy, and then you want to stop the therapy. And that is a real possibility now. Whereas somebody else might say, no, I'm very happy staying at home and I will just take the pills at home. And that is that's the kind of discussion that could be quite challenging sometimes. And it is the clinician responsibility to give all options to the patient so that they are completely aware of it. And Nick briefly asked me to talk about the continuous versus fixed duration therapy. And the concept is that the continuous therapy is continued as long as the drug is working. So we have got drugs like ibrutinib, acalabrutinib, zanubrutinib. These are irreversible inhibitors of a protein called BTK in the CLL cells. And then there are some new molecules that are coming along, like pirtobrutinib. There is another one called nemtrabrutinib. So wonderful names. But these molecules are given as long as the treatment is working. And then there are other molecules like PI3 kinase inhibitors, and they've gone out of fashion. But then we have drugs like venetoclax, which could be continued as long as it is working for the patient. But for the fixed duration therapy, we as clinicians are very used to it. The chemoimmunotherapy was always a fixed duration therapy. So we always used to give 6 cycles of treatment or maximum 12 cycles of treatment, and then we used to stop. Because the main reason was the toxicity of these drugs. And they used to make patients unwell, and infections was the main problem that we see with chemoimmunotherapy. But now we've got this drug called venetoclax, which actually kills the CLL cell, and we can combine it with antibody treatment or with the BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib, or the new molecules which are coming along. And this has also allowed us to give fixed duration therapy, which means maybe 12 months of therapy with venetoclax and obinutuzumab, or venetoclax and BTK inhibitor, or with venetoclax rituximab for 24 months. So I think the concept is simple, that the continuous therapies, you need to have the treatment as long as it is working. With fixed duration therapy, we stop because the treatment has worked so well for our patients. And we can talk about it in a bit more detail later on. So in terms of the therapy options for this group that we call as relapsed refractory CLL, there are still 3 brackets in which I put the treatments in. There is chemoimmunotherapy, which is really gone out of fashion in somebody who had chemoimmunotherapy in the past, and the treatment outcomes are pretty poor, and it causes a lot of problems. And then we have got this class of drugs called the B-cell receptor antagonist, and in these there are 2 drugs called ibrutinib and acalabrutinib, and then we have got a number of another drugs called PI3 kinase inhibitors, which could be used. There is another drug called zanubrutinib, which is available in some parts of the world, and it will get its approval hopefully in the next coming year or so in Europe as well. And in some indications, in some conditions, it's now approved in US as well. And then we've got this drug called venetoclax with rituximab. And this is a very busy slide, but if I just ask you to concentrate on the middle of the slide, which is this red bar, there's a thing called median PFS, which is called the progression-free survival. So this means that if somebody had this treatment then how long would it take for half of the patients to progress? And there were a number of trials that are tabulated there where chemoimmunotherapy was used in relapsed refractory CLL. And I wouldn't go into the detail of that, but the upshot of that was that in all the trials, nearly everybody was getting the same results, that the half of the patients would be relapsing at 1 to 1.5 years, suggesting that this is not going to lead to prolonged remissions in our patients. And then came this trial, which was Resonate study. This is now a very long follow-up on this study, which was comparing this simple tablet, ibrutinib, and that was compared with an antibody treatment called ofatumumab. And this improved the outcome to nearly 3.5 years. So if I give this treatment to say 100 patients, half of the patients will still be on the drug and doing well at nearly 3.5 to 4 years on this tablet. Alongside that, there was another drug called idelalisib, and that was combined with rituximab, and that did improve the outcomes, but it was only nearly 1.5 years, so not really as impressive as ibrutinib. But both of these drugs were developed at the same time, and this really opened up the new drugs in the relapsed refractory setting. And then the other trial to talk about is the Murano trial, which was comparing this drug called venetoclax, which was given for 2 years in combination with rituximab, which is the antibody treatment, and it was given for 6 months. And that was compared with chemoimmunotherapy. And if this is the 5-year follow-up data, and what we can see is that half of the patients were progressing nearly 4.5 years after they had this therapy, which is much better than chemoimmunotherapy, the bendamustine rituximab, which was only 17 months, suggesting that this is a very good option for our patients in the relapsed refractory CLL. So I showed you the data for a BTK inhibitor, ibrutinib, idelalisib, and now venetoclax in combination with rituximab. And I think one of the difficult questions that any clinician finds themselves, and actually the patients as well, is that what to use in the relapsed refractory CLL. So we've got these BTK inhibitors I've talked about, whether we use venetoclax or whether we use PI3 kinase inhibitor. And one of the issues that we find as clinicians is that nearly everybody, especially in UK, had chemoimmunotherapy before, which means they had FCR treatment or bendamustine rituximab treatment. And then we know that they moved on to receive ibrutinib or venetoclax rituximab. So the path is pretty clear. But actually now we've got a problem that a lot of the frontline patients who are needing the treatment for the first time, have these novel agents in frontline setting like ibrutinib or venetoclax. So actually we don't have any data in the relapsed refractory setting to compare the two main drugs, the venetoclax versus the BTKI inhibitor. So actually there is no phase 3 data which can inform us to say which is the better option. And I think this is one of the very difficult questions that the clinicians find themselves in when they're answering the questions from the patients. And this is just an example of the number of, these are the big studies, the phase 3 studies, which led to approval of these drugs. And if you look at, again, the square bar again, you can find that actually very few patients had targeted drugs before they got the targeted molecules. So for example, in Resonate study, no patient had a previous PI3 kinase inhibitor or venetoclax. And that suggests that actually we are looking at the data in the relapsed refractory setting, which was related to chemoimmunotherapy rather than what we are dealing with now. What is very clear, and that is very clear to all the clinicians, is that the Bruton tyrosine kinase inhibitors are better than the PI3 kinase inhibitors. So this means if you take a drug called ibrutinib and you compare it to the drug idelalisib, which is the PI3 kinase inhibitor, the median PFS is 3 years in the ibrutinib containing arm as compared to nearly a year with idelalisib. And this is real world data, and Anthony Mato presented this data a few years back, and large number of patients, 683 patients in this data. But a criticism of this was that this is just real world data and we don't have a phase 3 trial, but actually we now have a phase 3 trial, and it was called ASCEND trial, where this second generation BTK inhibitor called acalabrutinib, and that was compared to idelalisib rituximab or bendamustine rituximab, and the investigator chose which therapy they get. And if you look at the 4-year follow-up data, just look at the blue curve, that looks much better as compared to the orange curve, and clearly suggesting that patients who are receiving the BTK inhibitor are doing better as compared to the patients who have received idelalisib rituximab or bendamustine rituximab in that trial. So that question is pretty much resolved, that we should be using BTK inhibitor rather than PI3 kinase inhibitor. And I think the first targeted agent, how would I choose? So I think it comes down to, with the BTK inhibitors, we've got the question of convenience. There's no infusions or monitoring needed. We've now got a long-term efficacy data in frontline and relapsed refractory setting. And we've got some data, and I'll show you that data for venetoclax after progressive disease on ibrutinib. But with venetoclax, we know that it is time-limited therapy. We know that there is no known cardiac side effects. And adherence is a problem because some of these drugs have got side effects. So you know that we are going to stop venetoclax in 2 years. And in few healthcare settings, there's a potential of cost savings with these molecules if you're using it for a fixed duration therapy. What about BTKI inhibitor versus BTKI inhibitor? Now we've got two phase 3 trials which have presented the data now. One is the Elevate RR study, and this was for patients who had relapsed refractory CLL. And the main thing is that these patients had 17p deletion, which is a high-risk disease marker, and an 11q deletion. And half of the patients got acalabrutinib and half of the patients got ibrutinib. So both are BTKI inhibitor. And really, there was no difference in outcomes. If you look at these two curves, actually, if you ask a statistician, there is no difference. And we normally look at the hazard ratios, and that was exactly 1. So really, there was no difference in outcomes in these in this group of patients. Where there was a difference was the side effect profile of the drugs. There was more cases of high blood pressure in patients who were taking ibrutinib, and also high rates of this problem called atrial fibrillation. And actually, above the age of 65, a large number of acalabrutinib patients also got atrial fibrillation, and we can talk about it in a bit more detail later on. There is another study which is going to be presented at ASH, and we're very excited to look at the data. This is against a relapsed refractory CLL. Half of the patients got this new drug called zanubrutinib, and half of the patients got ibrutinib. And all patients with relapsed refractory CLL were allowed to go into this study. I've just taken away the slides from what are available on the ASH website, and there is a difference between the two BTKI inhibitor, and it is in favor of zanubrutinib as compared to ibrutinib. So if you look at the 24-month time point, and they have made this bar thing here, so 79.5% of the patients on zanubrutinib arm are still doing well as compared to 67.3% in the ibrutinib containing arm, telling us that zanubrutinib is superior in this analysis. Now, there is a lot more data that I would say we need to look into. There is a question about how many patients have stopped ibrutinib early on due to intolerance in this study. And this is what Brian was talking about early, and that could have an impact on the PFS as well. And I would say that it is good to look at the data in detail when it will be presented by Jennifer Brown at ASH in the late breaking abstracts. But clearly, we might be getting a better BTKI inhibitor than ibrutinib, but I think the jury is out at this moment in time. What is different between zanubrutinib and ibrutinib is that, again, the atrial fibrillation rates are much lower in the zanubrutinib arm of the study, but the blood pressures are raising as much as in the ibrutinib arm of the study. So much smaller, shorter follow-up on this study, but again, interesting that this drug might improve the outcomes for our patients. So one of the questions really is that if somebody has started BTKI inhibitor, what to do next? Whether we go on to venetoclax or PI3 kinase inhibitor, or whether we go back onto another BTK inhibitor. And there is some data that actually if somebody is intolerant to ibrutinib and they move on to acalabrutinib, the outcomes are pretty good. So if we can choose a BTK inhibitor which is more tolerable, then we will get the same responses. So some of the patients who can't tolerate ibrutinib, we managed to get them onto acalabrutinib on this study, and still the outcomes were very good, suggesting that moving to another BTK inhibitor is possible. And if we look at another drug, venetoclax, whether that could be used after ibrutinib or another BTK inhibitor, if you look at the blue charts, the best drug which works in this setting is venetoclax. And if you use the other BCRI inhibitor, which could be idelalisib or could be another BTK inhibitor, it's okay, but best is venetoclax in this setting. And there is some trial data actually to suggest that patients relapsing on ibrutinib or idelalisib will do very well on venetoclax therapy. So in terms of how we sequence is dependent on what the drug we're using. So if we use BTKI inhibitor first and somebody is progressing on a BTKI inhibitor, then the best option is venetoclax plus minus rituximab. And there are pros and cons of using those. But if venetoclax and rituximab patients become resistant to this combination or relapse on this, then you go down to this route, which is the PI3 kinase inhibitor, which is idelalisib or divarasib, or we consider cellular therapy. But if somebody is intolerant to one BTK inhibitor, then you can use an alternate BTK inhibitor, or you can use venetoclax with rituximab, and you can cross over as needed. So mainly working on a BTK inhibitor and venetoclax-based therapy and trying to get the maximum out of it is what I'm alluding to here. So if somebody has started with venetoclax-based therapy, I think the answer is pretty much the same, that you move on to a different class of drug or use the same molecule. So this is some data, real-world data, where people have used BTK inhibitor after venetoclax-based therapy, and the response rates are pretty good. There's Australian data as well, US data, but this is all real-world data. This is not trial data, which is showing that actually using a BTK inhibitor like ibrutinib, like acalabrutinib after venetoclax is effective. In Murano study, where patients had venetoclax, rituximab, or bendamustine rituximab, when patients relapsed in those arms, they received BTK inhibitor, and the response has been pretty good, suggesting that this approach is reasonable as well. In some patients who've had venetoclax rituximab for 2 years, and then they stop therapy for some time, then whether we can use venetoclax again is another question. And that's been looked at in 2 studies. One is from Murano and the other one is MD Anderson. Small number of patients, but actually some patients do respond to venetoclax again. So that is a reasonable option. And actually there is a reasonable size trial which is looking at this question, whether we can reintroduce remissions by combination of venetoclax with CD20 antibody. So I'll apologize again for this complicated diagram, but again, if somebody is relapsing on venetoclax and rituximab therapy or anti-CD20 antibody, then we use BTK inhibitor. That's usually our choice of therapy. If there is progression after therapy completion, then it's either venetoclax-based therapy or a BTK inhibitor. So you're working around the same molecules, and then the end result is same where we go down from there on. And I think that's the problem. That's the area where we as clinicians are now struggling, where we use these molecules either in frontline setting or first relapse, and then both drugs, patients become resistant to both drugs due to one reason or another. And in those patients, unfortunately, the responses are not very good with whatever therapy we give them. So this is just the data from Australian study, which showed that the overall survival was very short in patients who actually progress. And these are the patients which we class as double class resistant CLL patients. Is there hope there? Yes, there's always hope. And this is the drug I was talking about. This is the non-covalent BTK inhibitor called pirtobrutinib. So where ibrutinib or acalabrutinib binds, it's a very specific point called cysteine 481, whereas pirtobrutinib is working in a clever way in blocking the BTK in different places, as well as it comes off and then moves back on to occupy the BTK. And this study has shown that even if patients had 5 lines of therapy before, a number of patients actually have benefited from this molecule. There is another drug called nemtabrutinib, and this data is also going to be updated at ASH, which is showing good results. Another question is whether we still can do allogeneic transplant in novel agent era, and there is some data with small number of patients who are fit enough to have a transplant after 1 or 2 novel agents. And there are some patients who will benefit from the transplant, but it very much depends on which country you are, what is the availability, and how suitable you are for the transplant, and what donor source we are using, whether it is the stem cells being taken from a sibling or whether it's being taken from an unrelated donor. Is there any other thing like CAR T-cell therapy? And that's one of the important questions that's being asked in patients with this kind of problem. This is the data from Transcend CLL04 study. There's a CAR T-cell product called Liaison, which was combined with ibrutinib and was given on its own. And small number of patients, but we were shown that actually some patients did benefit from combination of ibrutinib with this CAR T-cell product, and there is some more data which is coming along, and this CAR T-cell product is the basically the first in line to actually move into the phase 3 designs. So I think what's on the horizon, I think if I have to cover more complicated things that we can talk about it, but I think the way I see it, we have to target the risk groups for intensified therapy. So some of the patients with high risk disease, which we can identify those patients now, if they are not achieving very deep remission, and I've not talked about MRD, then whether we can target those patients to give them more therapy to get them into deeper remissions. We need to think about combinations, because clearly when we are failing these BTK inhibitors and BCL2 inhibitors, we have to think out of the box and try to use intelligent combinations to circumvent resistance. And then there are immunotherapy. So there are CAR T-cell products which are coming out. There are different areas where we can specify these CAR T-cells, and then bispecific antibodies, which are more advanced in lymphoma space, are coming into CLL as well. And one of the problems with what we find in CLL is the issue with what we call as T-cell impairment. So we need to make those T-cells active so that they can kill the CLL cells. But I think it's fair to say that the CLL care has transformed over the last decade. We're not really using any chemotherapy now, which is good. Sequencing is dependent on a lot of therapeutic options, but that is really, I would argue, would be dependent on patients' preferences. We need to individualize therapy based on the comorbidities. We can now do better combinations, looking at the CLL disease bulk, high-risk genetic features. And then also, I would argue, in the UK, we do look at the MRD status of our patients. And depending on the response to therapy, our trials are looking at the question whether the duration of the therapy be dictated by the MRD status. And I think these questions will help us to prevent resistant disease, which is really what we want to avoid in CLL. And I think I will stop there.
Thank you, Tal. A really comprehensive talk, and I'm sure many in the audience will be uplifted, and obviously reading some of the messages, difficulties in countries where there is limited access, not so uplifted. I can attest as a long-term patient myself, as it just seems like yesterday when we were looking at the first trials and the advent of the arrival of PI3K inhibitors and the first BTK inhibitor to where we are today. As long-term patients being through previous therapies, a whole world has opened up for us, and with that a lot of complexity and difficulty that we didn't imagine that we would have. Good difficulties, but difficulties. Before opening up to the questions, and thank you everybody for providing questions, and please do keep them coming in chat. Really, really helpful that we can address some of the topics that you want to. Maybe I could just throw it over a quick summary. Early impressions. What's come to mind to you, Brian, after listening to the current landscape and talk of areas that you might wish to discuss, and the same, Lilia, to follow with Brian. Brian, have you any immediate thoughts that have sprung from Tal's presentation?
Yeah. First, thanks so much, Tal, for that overview on this really kind of complicated, nuanced topic. And I think you tried and did a good job of making it clearer. The first thing that strikes me is echoing on what Nick had to say, is how different things are today than when I was diagnosed in 2005. Essentially, at that time, for what was high-risk disease, your only option was a transplant. Really, that was about it, because chemo, we knew didn't work. And now when I look, and all patients can benefit from these changes, that the prognosis is so much better. So I think one of the important things we have to do as patient advocates is make sure people are always looking forward, not backwards. Because if you look backwards at some of the statistics, they can be pretty depressing. But if you look forward at all these changes, I think that that's pretty darn exciting. With one significant exception, and I think you touched on that, is what the heck do you do if you fail these two great classes of drugs that we have? If you failed the BTK inhibitors and you failed venetoclax, which is the only BCL2 inhibitor, this double refractory disease. And the data that you showed from Australia was, frankly, quite dismal. So that's another point we have as advocates, is CLL is not a solved problem. We are blessed with these fabulous drugs. And for a lot of people, that's all they need. They can run out the disease. But if you're young, or if your disease is more aggressive, and you burn through those two drugs, maybe you burn through them in 5 years or 7 years, then it's clinical trials, it's experimental options, it's tough. So those are the two takeaways: how much progress we've made, how much better things are, but we're still not, we're talking soccer analogies right now, but let me use a baseball analogy. We still don't have a home run here. We don't have really, for almost everyone, curative therapies. And kind of it's two strikes and you're not quite out, but you're almost out now in CLL still. And that's my concern as a patient and an advocate. And that's why I'm pushing for clinical trials and more research and more funding for CLL.
Thanks, Brian. Yeah, a revealing observation. Tal, did you have anything you wanted to add to your previous comments in that area?
No, I think it's very well summarized by Brian, as he always does. I think what I would say is, yes, it seemed to me like that we were running out of options after BTK inhibitor and venetoclax. And the issue that we find ourselves now is that whenever we find a good drugs, we move that into the frontline space. And I think one of the things as a clinician and as a patient that I talk to about is how to maximize the output from these drugs. And I think a lot of trials that are looking at these questions is to use how best we use the combinations, when to stop the treatment, and if we stop the treatment, when to reinitiate the therapy so that we can get the maximum out of these two classes of drugs, which is fantastic. But then there are other molecules actually, and I didn't talk in detail about. There's a lot at ASH to be looking forward to in CLL. And these are bispecific antibodies. There is another class of drugs called BTK degraders, which is coming along. There is hope in terms of combining different therapies and then to reduce the duration of therapy. So there's a lot happening in that space at the moment. And I feel very optimistic that this is the right time to be working in this space so that we can utilize the best for our patients. But I think I would encourage anybody to explore the clinical trial options, because that is looking 5 years down the line what would be available on the clinical trial. And I think that is definitely the way to go in future, really, because I can just give you an example that when we were running the FLAIR trial, and Lilia can comment on that as well, when we designed the trial in 2014, ibrutinib was the only drug which was really everybody was talking about. And by the time we were going to read out, the whole world has changed in CLL. The question we were trying to ask at that point has completely disappeared at that point. So things are moving on that quickly, and the clinical trials are trying to ask those questions. I would really encourage if somebody finds themselves in that situation to look out for clinical trials if that's a possibility.
Thank you, Tal. From that perspective, it reminds me of a very similar situation that we were in 13 years ago, and it's getting these new treatment technologies now into the space and access challenges. I think we're going to touch a little later on how patient advocate groups can become involved in pressing for access. It's obvious that there needs to be more drug in this space and more options. Lilia, I could offer you the same courtesy that I offered Brian. Before we've got a little bit of time to answer everybody's questions. Before we do it, anything that struck you with Talha's talk?
Thanks, Nick, and thanks, Tal. That was a very comprehensive presentation. And just following on really from what both Brian and Nick said, I mean, again, my experience is the same, that when I was first diagnosed with CLL, there were no choices, and it was one route. But choice is a double-edged blade, and you quite rightly emphasised the importance of patient choice in that, particularly in this kind of clinical area where, you know, folk have had their CLL for quite some time by the time they get to this point. But maybe you could talk a little bit about how to facilitate, how should we have those discussions? How should patients inform themselves before they go into that? Because they can be quite challenging conversations, particularly at a time when you feel that your disease is slipping away from you a little bit. So it's just that choice. I think it's great that there's more choices, but I'm well aware that it's a bit of a double-edged sword. I was given 3 options when I relapsed. I found that really difficult.
Yeah, I think choices can be good and can be bad, Lilia. And I think the issue really is that in the frontline space, I will be honest with you, we are spoiled for choices, and we will be spoiled for choices in the next coming few years, because we are going to have a lot of molecules that will get approvals, and then we'll have to decide, which molecule we're going to use. But there are some basic things that we know about now, that the BTK inhibitors on their own, we need to keep going with that as long as it is working for our patients. But we are asking that question now in UK with another trial, whether that's really, that statement is true or not. And we are doing a trial called Static Study to essentially limit the duration of BTK inhibitors. So that's another example of where choice becomes available, but in a context of a clinical trial where we would be able to answer the question. But then I think in terms of how I tell my patients that this is what the options are, what I can get you as a standard therapy. And then I will ask patients' preference on that, really, whether they want continuous therapy or whether there is a role of fixed duration therapy, but also then look at the comorbidities, whether somebody has got a heart problem. And in that case, I might say my preference is more this as compared to this one, just because you have this issue. And then the third issue is about the clinical trial question, really. And what I try to give, when I speak to the patient, I try to give that alternative option as well, and give the pros and cons of that option as well. And I think if you've opened it up and tried to explain everything to the individual, then I think you've done your job, really, to maximize the information that you can get in front of the patient. And some patients will, I'll be honest with you, will say, "Doctor, you choose for me." Then some patients will go back and analyze all of what I've said, and they will come back with 50 questions, and then I'll have to answer all of those questions, why I've made those statements. But eventually, when we made that decision, I think it's a journey we need to take together from there on. And we need to be part of that journey right at the end of the treatments, whatever we choose, whether we choose venetoclax or obinutuzumab or a trial or a BTK inhibitor. All of that needs to be kind of streamlined and taken through. So I normally say to all my patients is that it's a journey we need to start from, and whichever route we are going to take, I'll try to inform you. I'll try to help you as much as I can. And if you get that kind of bond with the patient, then most of the times it works all right.
Thanks, Tal. I was going to ask, looking at the question from a different end, is that obviously the empowered patient does better and is more able to engage in their healthcare discussions. And looking at what is a very complex question and scenario, how do we empower patients to provide concise information that's understandable to help with this decision making? Because without being informed, we can't rely on everybody being a Tal. And I think that's the case. And I know as patient organisations, we do a great deal to provide literature, information, and keep pace. That's part of the reason for this webinar ahead of ASH, to help inform patients and advocates going into ASH to be able to collect the latest information and summarise that in a tangible way. Lilia, I was just wondering if you've got, I know that this is a burning topic of your own there about empowering patients and involving them in shared decision making. Have you thoughts in this area? And I will move on from then, because we've got so many terrific questions from everybody that are very disease specific, very specific.
Yeah, maybe just very quickly, I think it would be a great, in a way, it's a new area opening up, because there is so much. Previously, there wasn't choice, and maybe it's an area that we should be looking at doing a bit of research to find out what people want to know. What do we need to know in order to make those decisions? And everybody needs to know different things. Just even the questions that you ask are very personal. So I think it's an area to me that's opening up that we need to think about much more carefully in CLL maybe, and perhaps look at different ways of explaining things. And also making, your talk really underlines, Tal, the importance of making the results of research available to people.
And let me add to this just one other piece, is that these are not, you know, when you see a doctor and you have a strep throat, the doctor is going to prescribe penicillin unless you're allergic to penicillin. There's not a lot of debate. It's very straightforward in how you manage a strep throat. But in CLL, especially in the relapsed refractory setting, but even in frontline therapies, these decisions are extremely complicated, as Professor Munir laid out. And your own personal preferences, your own past experience, the medical data that's in front of you. But at some point, you have to make a decision. And there's often not wrong or right decisions. There's often, a lot of these are a coin toss. And you know, my experience, and I've been faced with a lot of these in my 17 years of CLL, having had a bone marrow transplant and all kinds of things that probably, if I had the options that I had today, I wouldn't have chosen, but I didn't have those options then. You just have to make these decisions. And just from my own personal experience as a patient, is once you've made the decision, you kind of got to go with it. You know, I mean, unless you get some loud warning, wrong decision, look what's happening here, stop before you get further into it. But generally you go with it and you don't have regrets and move forward with it, because it can drive you crazy. There can be, you know, paralysis by analysis in CLL. And, you know, not every country, not every circumstance has all of these wonderful options. But if you do have these options, at some point, you just got to decide and move forward, and then live regret-free that that's the decision that you've made, because it's not clear. I mean, as the data was presented, that, you know, the BTKs are better than venetoclax, or venetoclax is better than the BTKs, or this one first, or this one in combination, and then that one, or that combo with this one. You know, maybe we'll have those answers in 10 years, but we don't have those answers now. So you just have to look at what your personal preference is, and then live with it.
Thanks, Brian. Both really honest and direct answers. I think as obviously this is a CLL Advocates Network event, and many on the call advocate and are supporting patients in their own countries, that I very much like the idea and the suggestion that Lilia had, was looking that maybe this is something we could undertake as advocates, as a network, to actually research what patients need to be able to help with decision making, and whether we could investigate through research surveys, creation of a toolkit and a route to gain the information that patients would need to feel empowered to be able to make these decisions, and where to go for that information. Yeah, a really complex, exciting landscape. I think what we should do now is move on to everybody's questions. I'll bear with me while technology-wise I just try and adjust my screen so that I can do this. So I'm not going to follow any particular order at the moment. I did pick up on one question earlier, and I think you did touch on it. In the decision-making process, when you say it's a decision potentially between two major therapies, a BCL2 or a BTKI, are there any key decisions that, you know, when you're making that decision and having that discussion with the patient, that you would focus on for a preference of those, Tal? That's one of the questions that we've had.
So I think a very good question. I think that's the main question that puzzles most of the CLL physicians. I think the way to explore that question really is in the relapsed refractory space. I normally would look at, first of all, what does the patient's preference itself is, but I think most of the times I'm looking at if there are any cardiac medications that the patient is taking. So looking at baseline high blood pressure or irregular heartbeat could be an important thing. The medications that the patient's already taking, that is a big factor. And I normally would assess the heart anyway now. So I do an ECG and do a heart scan so that I've done all my baseline workup, so that I'm sure that if I'm going to give somebody BTK inhibitor, they're not going to fall apart because of the BTK inhibitor. And I think that's one of the messages, one of the things that we've learned over a number of trials over a number of years. The second thing is looking at the genomics of the disease as well and seeing, how does the profile looks like now. So doing those tests at that point is very important. And I wouldn't go into the detail of that, but for every individual patient, that will tell me which flavor of treatment might be better for that individual patient. And then I will put it down, all of those details in front of the patient and say, this is what I think, is the option that I've got for you. This is I'm erring towards this side, but I'm very open to the idea of using the other option as well, if you feel that that's what you want to go up to. With the venetoclax question, really, it's the question about, are you happy to come to the hospital for blood test monitoring? Are you worried about COVID risk as well? And a question about using rituximab. All of those things come into play. So there are some CLL determining factors. There's some which are patient-related factors, and something is what is around us, the environment at the moment, what is the COVID levels at the moment, how good is the immunity, have you had all the jabs that you needed to have? All of those things come into play before we come to a conclusion. But I would say that whatever decision we make at that time, then I completely concur with Brian that we need to utilize those drugs. Because if we underutilize those drugs, then we have actually lost one major drug in our armory, and that we really don't want to do.
Thank you, Tal. I see so many questions that a lot of this is adding more questions. Whilst we're kind of on topic, there's several questions about preference around BTKI use, which therapy to choose. It is one, are they definitely better? Is there a difference between them? Is it an in-class issue for BTKIs with regards to side effect profiles? Is the data mature enough in the later zanubrutinib and acalabrutinib second generations? And this is a personal one, but do you have a preference? I guess I've lumped them all together from that point of view. Apart from obviously the pirtobrutinib, which you mentioned there being a non-covalent mechanism and a totally different binding mechanism. Have you any thoughts across the three?
So I think, again, very good question. And I think I partly alluded to that. So we had Elevate RR study, which showed that acalabrutinib and ibrutinib are equally effective drugs, where acalabrutinib has got a better safety profile. The Alpine data, which is looking at zanubrutinib versus ibrutinib, is interesting because this is the first trial where a BTK inhibitor like zanubrutinib has beaten ibrutinib in terms of the effectiveness. Now, the issue is really around the number of patients who stopped ibrutinib in this study. So even if at the 12-month follow-up period, there were lots of discontinuation in the ibrutinib arm. And if you look at the historical data with ibrutinib, in Alpine, the ibrutinib patients have really done badly as compared to what we've seen. So what I'm trying to say here is that we have got only a short follow-up on this study. We have to look at the caveats. Is zanubrutinib a better drug than ibrutinib? Based on the phase 3 data, yes, it is. Whether zanubrutinib is better than acalabrutinib, we can't say that because really this phase 3 trial was not looking at zanubrutinib versus acalabrutinib. And if there was a trial which was looking at the question, it may be that both drugs might be equally effective because we see less intolerance problem with acalabrutinib. So when I'm going to be talking to my patients, I will be talking all about this, giving all the caveats that I feel are there in this trial, and then come up with the best, advice that I can give to my patients. I think this is the first study, which is very exciting to see, that if really zanubrutinib is better drug, then most probably we will be using it more frequently. But I still hold my breath to kind of look at the data in detail before making up my mind.
Thanks very much, Tal. I think that answers the question. Time will tell. Yeah. A question's been thrown in, which I find interesting. Sort of the stronger combinations. We talked about the bringing together of BCL2 venetoclax and ibrutinib in the front setting that might have caused double resistance issues for people longer term. And we've seen some of the data in the relapse setting with venetoclax plus a monoclonal not producing the same overall survival data. So somebody's raised the question, what about bringing, are there studies of bringing venetoclax plus a BTK into the relapsed refractory setting? I asked the question also with personal interest, because some of us long-timers didn't have any choices in the beginning. We basically had FCR or ZIP, and we wanted to get a treatment-free period. We wanted to get a remission. And as we move forward, some of these options are no longer available for us, and some patients may be younger and fitter. Is this something that's likely to happen? So I'm kind of adding to the words of the question that was fielded.
So I think the BTK inhibitor plus venetoclax data would be there's a whole CLL session, which is the doublet session at ASH this year, which is just looking at ibrutinib and venetoclax combination. I would be presenting the data on Clarity, which Lilia participated in, and we have got now the 5-year follow-up data on that study. So unfortunately, I can't disclose the results, but They look good.
Are you presenting at ASH?
I am presenting at ASH,
We look forward to that.
And then there is the FLAIR data, which is, I can see there's one of the questions there as well, with the combination of I plus V and whether MRD guided approach is appropriate for some patients. Purely a trial question, and there is some interesting data on FLAIR that I would be presenting, but it's got a shorter follow-up at this moment in time. The issue really with the question of using a doublet in the relapsed refractory space really is that the success we found in the relapsed refractory space translated into movement of these molecules in the frontline space. So that resulted in a number of phase 3 studies looking at those doublets in the frontline space, and that data is coming through, which is exciting. But that leaves a space in the relapsed refractory CLL, where actually we would need to do more trials to see that if we re-expose these molecules to our patients, whether we will get the same benefit. Probably the answer to that question is yes, but I think we still need to do those trials.
Thank you, Tal. I'm going to burden you with a few more questions before I talk to our patient panelists, because I think it's important to answer people's questions. Somebody's asked about BTK becoming BTK when it becomes ineffective. Is there an immediate or a gradual decline in effectiveness, and what are the indicators that it may be time to start considering the next treatment option?
That's another very good question, and if you follow your blood counts, what we find with BTK inhibitor is this lymphocytosis, and then the B cells or the CLL cells start to decline, and then they plateau over a time. And we've looked at the MRD data, which we really don't need to do in patients who are on BTK inhibitors, is a plateau, which means that the CLL is there, and essentially the numbers of cells which are dividing or dying are pretty much the same every day. And then over a number of years, there's something interesting starts to happen, that the lymphocytes then start to slowly creep up over time without us picking up any lymph nodes or anything like that. And there's some data to suggest that normally when we start to see that process, that it takes about 1 to 1.5 years before a clinical progression happens. And if you are working in a research lab, as I'm doing, we can actually pick up that cysteine 481 mutation that I was talking about nearly 1.5 to 2 years before a clinical progression happens. So there could be indicators that will tell us, and I normally speak to patients about that yes, I'm picking up something here. I might get you on a trial now in the next 12 months or so. So be ready that we're going to move on to this, or we might have to go to its venetoclax-based therapy at that point. So actually there are indicators that you can see more in the relapsed refractory space as compared to the frontline space.
Thank you for a really focused answer. That hopefully that's very helpful to the person that asked. There is a question here about reversible non-covalent mechanisms, and I think it's quite technical. And I'm not going to ask the question, but I'm just going to let the person know who asked the question that tomorrow we have Professors Chris Fagan and Chris Pepper, who are looking at the development in BTK-focused therapies. And there's a basic scientific overview talk to help with some of the understanding in that area, as well as Professor Fagan giving the clinical implications talk. So I'm not going to ask that question, but I will refer you later on in the talk to the session tomorrow that will be able to answer that for you in a meaningful and understandable way. I'm going to lead on to two questions that kind of lead into each other that kind of remind me of people have seen my discussion with Nora and Onyeki in Nigeria, and issues obviously with the pandemic. I'm the second one to mention COVID today, but more in terms of the outcomes with chemoimmunotherapy that is in use still, as obviously it sounds like a mainline therapy. So the question is, does chemotherapy still have a place in the treatment of CLL, especially in the relapsed refractory setting, which we don't see it very often in our part of the world? And mixed into that again is access to clinical trials. Are clinical trials, so it's two questions in one really, trying to save a bit of time. Are clinical trials available all over the world, and how can we improve this?
So unfortunately, the answer to that question is that second question is that no, clinical trials are not available everywhere in the world, and that is unfortunate because CLL is a worldwide disease, and actually there is some data where trials have been done in the parts of the world where normally clinical trials are not that successful, or it's not a forte, but a lot of the data from Africa tell us that the CLL profile of those patients is different to the CLL profile of the Western population. So we've done some work on another problem called monoclonal B-cell lymphocytosis, which means that we can pick up the CLL cells in the blood, and actually we can look at the marker on the CLL surface, and we can tell whether this has changed from what we were born with or not. And we had some samples from Uganda, and their MBL population is very different to our Western population. So I think the issue really is that we haven't done enough clinical trials in other parts of the world where we should be doing. But at the same time, BeiGene is a company which actually developed all the drug in China and then has moved across now, and they have got a very exciting pipeline now. So things change over time, and hopefully we can incorporate clinical trials all around the world. The second question, really, the first question really was about chemoimmunotherapy role. I would argue in Western world, no, we don't have a role of chemoimmunotherapy now. But if you don't have any options really, then yes, we have to treat our patients. But then I would argue that that's where the advocacy comes into play. Ibrutinib, rituximab, these are the drugs which are going off patent now. And one of the things which can be done is to reduce the price and availability in those countries so that molecules could be used effectively. And these are very effective drugs for CLL patients, which unfortunately a large part of the world can't access.
Very true. Thanks for raising that flag. I think that's a banner that we're going to have to raise as the advocate, the international advocate community. And thanks for also raising it. We forget how time marches on and patents run out. Thank you for that observation, Tal. I'm trying to skip through questions. There's a simple that hopefully is one for you to answer. Somebody asking about sort of use of MRD to direct therapies or measurement within treatment with a BTK inhibitor. Is that relevant regardless of how long a patient has been on the inhibitor?
So MRD question in context of simple BTK inhibitor is not relevant as such, but we, like I said, we are doing a trial in UK static, in which patients who've had 6 years of ibrutinib or 3 years of ibrutinib in the relapsed refractory space will be randomized to either stopping therapy and monitoring, or they will continue ibrutinib. And the main focus of that is that the patients who will stop therapy, then we will monitor them very closely, doing the MRD test to see whether there is any chances of relapse. And the reason for doing that is we know from some other cancer data that if we use intermittent therapy in patients who need continuous therapy, that actually reduces the risk of resistance and prolongs the longevity of the drug as well. So that trial is open now in UK. So I'm leading that study at the moment. We will hopefully be able to, I will be able to come back in many years from now to give you an answer on that.
Well, I hope we're still here in many years from now to actually be able to challenge you with that question, Tal. Look forward to it.
Nick,
sorry.
could I just jump in with a clarification,
please.
which is just that you do restart the treatment if you don't you? Yeah.
Okay. If you relapse, you restart. Yeah.
If you have clinical signs that the things are, so basically if your lymphocyte count start to go up, then you start therapy. We're not waiting for clinical progression there.
Okay.
In that study. Thanks.
Thanks so much for that. I've got my eye on the clock and I want to end up with some important questions if I can, but I'm just sort of whizzing through where we were. I don't know how relevant it is, but how important is it that treating physicians and patients in the relapsed refractory setting consider subsequent treatment options when trying to make their treatment decision? Is that important to the patient? Is that important to the clinician? Is that part of the consideration? I think we've answered some of it.
I think it's always very important because I think that's one of the major things that we need to consider. That's the whole point of showing the sequencing pathway, and I think all the physicians should go through that with their patients. I normally put down clinical trials there at each point, really, because really we've got very good clinical trials that are exploring those questions at this moment in time. And there are, I can tell you, a number of drugs which are being utilized in phase 1 and phase 2, which are very early phase studies to look at those double refractory patients. So I think it's a very important question to go through and give all the options to the patients so they completely understand where they stand, where they're standing now and where they will be standing in 4 or 5 years time. So if you're talking about when are, and if I've said that 4.5 years is the time point where I would expect half of the patients to need another therapy, then it's the patients should ask me, what are you going to do then, doctor, at that point? Have you got an option for me there at that point? And I will say to them, these are your options today. In 4.5 years' time, that might be slightly different from where we stand now.
Thank you, Tal. It can seem like a game of chess, and trying to create stepping stones and opportunities to extend your window of vision is important from?
Yeah, the principle, if I'm going to jump in quickly, we actually presented this as a game of chess when we did a webinar on planning your steps ahead, because you've always, like a chess game, got to think 2 or 3 moves ahead, because essentially all therapies in CLL are palliative. And palliative doesn't mean that you're going to die. Palliative just means that they're not curative. It just, so every time you're just kicking the can down the road, and hopefully you get a long kick and it takes you a long time to catch up, but then you're going to need another kick at the can and probably another kick at the can. So you want to make sure that you have that planned out as best you can. That used to be more of a problem in the chemotherapy era because your options would get more limited. But as Dr. Munir pointed out, you can kick the Ven clan first and then the BTK can, or the BTK and then the Ven can, or the combo and then this one. So it's less of a concern that you're precluding options. But one thing I've had to think about as a patient and using clinical trials is sometimes you're excluded from clinical trials if you have had certain therapies or if you haven't had certain therapies. So that can be an important consideration in terms of your plans if you think a clinical trial is going to be part of your future.
Thank you, Brian. Lilia, anything to add? I'm just about to wind everything up because I promised to keep us to time.
I mean, maybe one thing to add there is those conversations can be not everyone's got different things they want to know. I guess one thing to say is also, I'm an advocate for asking questions, but I've learned from my own experience only to ask ones that I want to know the answer to, because once you've heard the answer, you can't unhear it.
Thank you. Very point. But exactly, sometimes a question makes the question too complex to be able to answer, and I get that. I'm just thinking it's time to sort of draw the discussion. I've got a couple of slides just to end off on, just information-wise. But I guess really, if we could end this session, just to get everybody's perspectives. Again, we started with the difference of the landscape today compared to how it was to us 13, 17 years ago in Brian's case. But I guess really, what's your takeaway at the moment of the landscape today as a long-term patient after several lines of therapy or in your second line of therapy about the future moving forward? How do you feel today compared to how you did before your first line treatment? I asked that to either patient first. Brian, Lilia, what are your thoughts?
Well, I'm thrilled to have these choices. I wish I had them. You know, one of the things that we say to patients is never a good time to be diagnosed with CLL, but there's never been a better time to be diagnosed with CLL, except maybe tomorrow or 2 years from now, because there'll be better therapies in 2 years from now, or at least better understanding of what the best way to sequence things are. So I'm extremely happy with what's going on. But as I said before, it's not a done deal. And we need to look at options beyond the big two that we have in CLL. We have 2 big classes of drugs. We have all these drugs, but essentially at this moment, we have 2 classes of drugs. And if you fail, I mean, if you relapse or refractory to ibrutinib, then you're also relapsed or refractory to acalabrutinib and zanubrutinib. It's very unlikely if one of those doesn't work, that the other ones will work. It's different if you're intolerant. So that's one of the things that Dr. Munir covered. So I'm always looking for, a 3rd class of drug, a 4th class of drugs. And that's why I'm excited about ASH and excited about the research that's happening to look at some of these new classes of drugs. So I'm thrilled with where things are at, but I'm still hungry and greedy for more therapies for myself and my fellow patients and my fellow advocates.
Thank you, Brian. Lilia, do you have a parting few words?
Yeah, I would absolutely agree with Brian. I think there's so much more. And often I was first diagnosed. I was told when I relapsed I would get a bone marrow transplant, and I still haven't had it. But I think there's still a lot more to do, and it's also it's very easy to talk about all these things, but a lot of people don't have such easy access to them. And I know I was reluctant to ask. I was in Clarity, I was given ibrutinib plus venetoclax, and my big concern was I was putting all my eggs in one basket, because what happened when I relapsed after that? There was nothing at that time, and I'm still not quite sure what's next. So I think my word of caution, I think it's really fantastic. There's lots going on. The thing CLL has taught me is not to look too far into the future, and maybe that's where I would finish. Enjoy what I've got and not worry too much about the future.
Thank you, Lelia. Really candid, really relevant. I guess I'll throw my penneth worth into the ring. Yeah, I didn't expect to be here now, 13 years on. I didn't expect to see my kids go through school. Certainly didn't expect to see them graduate from university with first-class honours. You know, those are my buckets, and so now it's a new world. But I think what my take of this is a CLL Advocates Network session. This is bringing together advocates from around the world who advocate for the needs of CLL patients and their families, and the clinical community. The clinical community needs the tools, and I think that we are duty bound now to look a little bit more closely at our patient experience and preference studies, so that we can actually evidence the needs in the countries where there are shortfalls, and work with the clinical community, with the payers being the healthcare providers, the funders of the drugs, and industry, to bring prices down and look at these patent issues, so that we can actually provide equity of access to these drugs around the world. And more importantly, build capacity in advocates to become involved in health technology access discussions in their local countries, to press for some of these new trials, new drugs, and also to help promote trials, build relationships between the clinical community and the patients to actually develop access and new trials in countries where there may not be, because it's coming clear that it's one story for one and a different story for other at the moment with everybody. But it is optimistic, and the future does look bright. And I certainly feel a lot more comfortable than I did those 13 years ago, but not absolutely comfortable. And I feel when I listen to people in other countries that don't have the access, the limited access that we have at the moment, and the decisions that we can make. Tal, I'm going to offer you the parting shot, and then I'm going to share a couple of slides and thank everybody.
No, I think I've spoken the most, really. I think you've covered it very nicely. Brian and Lelia and Nick, you've given a very good, fair perspective on where we stand with CLL. All I would say is that without patient advocacy, we can't move on forward, really. I think it is very important to have your voice, because your voice is heard. I'm afraid with the clinicians, we try whatever we can do, really, but I think we need your force behind us to make those changes. And I think the only thing I would say is that, yes, we have to, we made leaps and bounds in treatment of CLL, but I think we should take alongside the people who can't access these molecules. We need to advocate for them as well, so that pharma listens to it. There are some trials that we can't do in UK or in most of the Western countries now, because we think we've got better drugs, but those better drugs are still not a reality for majority of the world's population. And I think that is an important thing to consider.
Thank you very much to summarise that. And I think we will be looking and taking this into our strategy planning at CLL Advocates Network to support our community and look how we can engage better with patients in different countries to gain the evidence that we need to press for these things. I'm going to quickly share a couple of slides, see if I can get technology to work for me. Are we on slideshow? I believe we are. There we go. I mentioned earlier that we have a second webinar in the series tomorrow, just to let everybody know that maybe on the call that's not treated yet or has an interest in pre-treatment and first-line treatment, we will be covering those topics with some ASH updates as well in the new year after the festive break. Tomorrow we have another couple of gentlemen who are great friends of the CLL Advocates Network, who are going to explore, as I pointed out, some of the more basic science terminology and clinical implications of Bruton's tyrosine kinase targeted therapies. So please do join us. I think that's at a slightly earlier time at 5 o'clock tomorrow, and it's only an hour long, so we won't keep you on the call for as long if you want to join that one. Just some information about CLLAN services. I won't go into great depth about CLL Advocates Network. Please visit the website. You can get to know a little bit more about us and the resources and opportunities that are there for you. If you are an organisation or a member of an organisation that supports CLL patients and you're not part of the network, please join. I think listening to the talks today and the summaries today, that we really do need to combine our resources to be able to improve access and outcomes for patients in many countries around the world. And there are a lot of countries that don't have visible CLL support provision outside of the clinic. And we're obviously looking to work towards this next year as a major strategy with the clinical community to help develop these resources. So the website's got a plethora of information for you and the activities we're involved in. There's regular news updates, so you can pick that up on if you register for information and updates from CLL Advocates Network, you'll be sent regular newsletters and communications. If you're a patient on this call, if you're an advocate on this call, great resources are we have a global CLL resource hub, which is the result of a global survey of how CLL is provided and what support resources are available, information for patients in different countries. That's there for you on the website, and it's open access to everybody. So we are involved in global surveys and providing reports and recommendations. Last year and the year before, we carried out a series of surveys to provide regional reports, findings, and the recommendations. Those will come available, if not to you by direct email, will also be available on the website in the new year. And we're in the process of planning our events for next year. We'll kick off with a few more webinars in this series, but we are in the process of planning our workshops, regionalized to bring more people in from different parts of the world where there are different needs. And we're at the process, COVID back in the conversation. We're having a real challenge at the moment debating on what type of conference. We are really missing our face-to-face events, and that was evident in the chat. So hopefully we'll be able to update you on the website with that. I won't go into much more detail. There's much more on the website. If you want any more information or you'd like to become involved with CLL Advocates, contact us at info@clladvocates.net, and either Myrna or Nicole, our great team, will pick this up and get back to you very quickly. And you can always keep tabs on us, what's going on social media, CLL Advocates, at CLL Advocates, either on Twitter or Facebook. Those are the two areas we focus on. I'd like to just thank our terrific panel again today and everybody that's joined us from around the world. What a great audience, and really eye-opening presentation, Tel. Thank you, and a great bit of foundation work, I hope, to help those that are going to ASH this year to give a bit more understanding about this area in CLL treatment and care before the session. So thank you, everybody, and have a good day, good evening, and good night from me in the UK and our terrific panel. Thank you.